Hello, everyone. Good afternoon. Thank you for joining us today. Let's go ahead and get started. It is my pleasure to welcome you today to Captivating Updates in Chronic Lymphocytic Leukemia, a Shifting Paradigm. Before we begin, I want to share a few reminders. To participate in audience response questions, use your mobile device camera to scan the QR code that'll be on the slide. Click on the link that pops up and the poll will open through an app called Slido. You'll also see a tab in there for Q&A questions that you can submit. The other thing I want to highlight is there is an opportunity to upvote your fellow colleagues' questions. So if there's a question on there already that you're like, yes, I want to hear the answer to, that's how we'll prioritize asking the presenter at the end of the session. So please upvote things that you're most interested in. Please hold your microphone questions until the end of the session. You can submit questions on the Slido app throughout. And then you can use the aisles to get to the microphone, and again, you can also use the Slido app. Make sure to write down the unique CE session code at the end of the session in order to submit for CE credit in HOPA Learn. And see the conference program book for full instructions on how to claim those credits. For the sessions you missed, don't worry. You will be able to access them all later on demand in HOPA Learn, and the full conference on demand bundle is included with your registration, and it will automatically appear in your HOPA Learn account when it's released in May. Now it is my pleasure to introduce today's speaker, Dr. Bianca Patel. Dr. Patel is a clinical pharmacist practitioner at University of North Carolina Medical Center. I will now hand it over to you, Dr. Patel.
Thank you so much for that introduction. Good afternoon, everyone. All right, so we will jump right in. I have no conflicts of interest or disclosures. By the end of this presentation, we will be able to review current recommendations for the treatment of CLL, summarize the data derived from novel treatment strategies for frontline management of CLL, examine the use of non-covalent BTK inhibitor pirtobrutinib and CAR T-cell therapy in relapsed and refractory CLL, and then finally design a treatment algorithm for relapsed and refractory CLL. So before we jump into disease state management, just a very quick overview on what is CLL. So CLL is characterized by an overproduction of mature B lymphocytes. It is often diagnosed incidentally, so patients may or may not have symptoms. They may just be diagnosed with unexplained leukocytosis. However, you can see the diagnostic criteria for both CLL and SLL in the top right. CLL and SLL are very similar disease states. However, CLL, the lymphocytes are more so in the blood and bone marrow. However, SLL, they're in the secondary lymphoid organs. But you can see the diagnostic criteria there. And then if patients do actually present with symptoms, you can see what symptoms they usually present with. So enlarged lymph nodes, such as the spleen and liver, B symptoms, such as night sweats, weight loss, and fevers, autoimmune cytopenias, and then frequent infections that may be secondary to hypogammaglobulinemia. There are two main staging systems for CLL. There's the RISE staging system and the Binet staging system. You can see that they take into account of the same things, really: lymphocytosis, the presence of enlarged lymph nodes, hepatomegaly, splenomegaly, and then the presence and the degree of cytopenias. So for example, a patient that presents with enlarged lymph nodes but no cytopenias will be intermediate risk in both staging systems. However, a patient that presents with cytopenias will be high risk in both staging systems. Prior to the initiation of treatment, we evaluate FISH for deletion 17p and TP53 mutation status, as well as IGHV mutation status. Deletion 17p, TP53, and unmutated IGHV are associated with unfavorable prognosis and are much less responsive to chemoimmunotherapy. Deletion 17p and TP53 are also associated with worse outcomes with venetoclax-based regimens, as well as covalent BTK inhibitors. I will say that these are much less relevant than they once were in the era of chemoimmunotherapy. So with treatment advancements, it's unclear how much deletion 17p and TP53 do make, if they make as big of a difference in prognosis. And they are definitely much less relevant when it comes to making actual actual frontline treatment decisions. But you can see in the table on the left here the CLL International Prognostic Index and the factors that go into this, with deletion 17p or TP53 being the one that gives you the most points. And then there's also others, beta-2 microglobulin, IGHV mutation status. And then for the 5-year overall survival, you can see that deletion 17p or TP53 will automatically be high or very high risk, meaning that drops their 5-year overall survival to 60% or less, compared to 80 to 90% for those without. Not every patient with CLL actually requires treatment, so our patients with lower risk disease can actually qualify for observation, and then our patients with higher risk disease do typically require treatment. The most common indications for treatment are listed in the green box, so patients that have symptoms such as B symptoms or fatigue, for example, end organ dysfunction, bulky lymphadenopathy, recurrent infections, and then of course progressive cytopenias such as anemia and thrombocytopenia. So before we jump into the treatment recommendations for CLL, I do also want to take a minute to just appreciate how far we've come in the treatment of CLL. So we started in the 1950s with drugs such as chlorambucil, cyclophosphamide, moving into the chemoimmunotherapy era in the early 2000s. We had our first type 2 anti-CD20 targeted monoclonal antibody obinutuzumab in 2013, our very first Bruton's tyrosine kinase inhibitor ibrutinib in 2014, and then our first oral BCL2 inhibitor, venetoclax, in 2016. And just that, at that time point already, the treatment paradigm changed entirely for CLL, moving from chemoimmunotherapy to venetoclax-based regimens and BTK inhibitors. However, since then, we've also had a lot of major updates. So we have 2 second-generation BTK inhibitors, acalabrutinib and zanubrutinib, and then the ones I'll be focused on today, pirtobrutinib, our first non-covalent BTK inhibitor, and CAR T-cell therapy as well. The frontline therapy for CLL we can lump into 2 major buckets. So we either have venetoclax-based treatment, which is time-limited, or we have BTK inhibitors, which are considered to be indefinite or lifelong therapy. Regardless of deletion 17p or TP53 mutation status, we have 3 major frontline recommendations: acalabrutinib, a BTK inhibitor with or without obinutuzumab, zanubrutinib, and then venetoclax with obinutuzumab. The 2 regimens that I have highlighted here are the 2 relatively newer ones and novel combinations that I'll be focused on today. So venetoclax with acalabrutinib with or without obinutuzumab, and then ibrutinib and venetoclax. We also have some updates in second-line therapy, which I'll be discussing later, but you can see here that typically what we have done is that we, in the second-line setting, we give what we didn't start with. So for example, if we start with a venetoclax-based regimen, we'll switch over to a BTK inhibitor. If we start with a BTK inhibitor, we'll switch over to a venetoclax-based regimen. However, we have some updates here, the most important being using obinutuzumab in the relapse setting when historically we've used rituximab, and then retreatment with venetoclax and obinutuzumab, which I'll talk about, as well as our relatively new drug updates. These next couple of slides are here just for your reference. This is the landmark trials in the frontline setting. I did just want to point out here some things that's helpful for context is just the different populations these trials are evaluating, as well as just response rates. You will see throughout the presentation response rates can be kind of all over the place. Venetoclax-based regimens tend to have higher response rates than BTK inhibitors, and it's difficult to achieve CR in CLL. So those numbers will differ a lot, but progression-free survival is a somewhat more reliable marker of actual efficacy, and overall survival, since CLL is an indolent disease overall, is also difficult to make a difference within landmark trials. And this is our relapse data. And then the other big thing that's important when we look at some of the more recent articles here is the role of MRD. So MRD, or undetectable MRD specifically, has really become important outcome and appears to be predictive of progression-free survival and overall survival, especially in the advent of time-limited therapies. So on the left, you can see the frontline historical time-limited therapy, which is venetoclax with obinutuzumab. And then in the relapsed and refractory setting, we have venetoclax rituximab. And so you can see undetectable MRD, or UMRD, which is what I'll be referring to it as, in the peripheral blood was 74% for frontline OB-ven, and then 62% for the relapsed and refractory setting. But really what I want to point your attention to is the arrows. So you see for 24-month progression-free survival, for those that had undetectable MRD, it was 93% compared to just 37% for those that are MRD positive. So it's a very clear separation there. For relapsed refractory, it's similar. It's 94% versus 64%. So again, a clear separation. For chemoimmunotherapy and venetoclax-based time-limited therapies, there appears to be a correlation with undetectable MRD and progression-free survival. And so keep that in mind as we discuss MRD. MRD will be a focus of a lot of our trials going forward. And then another caveat here too is that all trials can have somewhat different methodologies for MRD testing. And so that's something we always have to keep in mind as we evaluate MRD in these trials. Okay, so that brings me to my first audience response question. Okay, so FS is a 71-year-old female who was diagnosed with CLL 2 years ago. She is now becoming progressively anemic and feeling fatigued and will require therapy for CLL. Which of the following is appropriate therapy for the first-line treatment of CLL? Note that she has a past medical history of type 2 diabetes. You can see her labs there, and then no deletion 17p or a TP53. Is it CAR T-cell therapy, acalabrutinib, pirtobrutinib, or rituximab? And I'll give us a few seconds to answer that. All right, so we can move on. Acalabrutinib, yes, that's exactly right. So BTK inhibitors or acalabrutinib are certainly first-line treatment option. Monoclonal antibody CD20 rituximab by itself would not be appropriate. Pirtobrutinib and CAR T-cell therapy, we'll talk about that later, but that is relapsed therapy. Okay, so let's jump into our first section, frontline updates. Here, I'm really going to focus on novel treatment combinations, our combinations with BTK inhibitors and BCL2 inhibitor venetoclax. Just want to preface this with, although we have come extremely far in the treatment of CLL, there remains a desire for an all-oral, fixed-duration treatment regimen that can be given in the outpatient setting. So thinking about our novel combinations, our BTK inhibitors and BCL2 inhibitors actually have, they may work well together, and I just want to take a minute to explain why. So we know that BTK inhibitors such as ibrutinib inhibits B-cell receptor signaling, which you can see on the figure on the bottom. BTK inhibition also results in mobilization of CLL cells from their protective microenvironment, and they result in reduced levels of the MCL1 protein, which actually then enhances their dependence on BCL2. Venetoclax is a BCL2 inhibitor. It induces apoptosis. So the thought is these two together can work synergistically, and they can target both resting and dividing subpopulations of CLL, and therefore lead to deep and durable responses. So the first trial I'll talk about today is called the CAPTIVATE trial, and you can see the treatment schema here. This is a combination of ibrutinib, a BTK inhibitor, and BCL2 inhibitor, venetoclax. I will talk about two different cohorts of CAPTIVATE, the fixed duration cohort and then the MRD cohort. I'll talk about the fixed duration first, which you can see is ibrutinib with a 3-cycle lead-in, followed by the combination of ibrutinib and venetoclax for 12 cycles. The difference with the MRD cohort is that after patients went through their 12 cycles of treatment, they underwent MRD testing, and then based off of whether they were undetectable MRD or not, they were randomized to different therapy. So starting with the fixed duration, this is CAPTIVATE Phase 2 International Multicenter Trial. This was in previously untreated CLL patients aged 70 or younger with an ECOG of 0 to 1. They received ibrutinib 3 cycles as a lead-in, followed by 12 cycles of the ibrutinib-venetoclax combination. And you can see the baseline demographics here on the right. The median age was 60, and ECOG 0 or 1, and deletion 17p or TP53 was present in about 20% of patients. So this was a relatively younger and slightly more fit population. So the results for CAPTIVATE for fixed duration, you can see here they're split out with patients without deletion 17p or TP53, patients with deletion 17p or TP53, and then all treated patients. So focusing on the overall response rates, they're exactly the same for all 3 groups, 96%. Undetectable MRD was 76%, 81%, 77%, still very similar. And then the numbers in the marrow are slightly lower, with the lowest being patients with deletion 17p or TP53. The 24-month progression-free survival was 95% and overall survival 98%. And they did demonstrate in this trial efficacy in all subgroups, including our higher risk patients that are deletion 17p or TP53. In terms of treatment-related adverse events, we can see here any grade adverse event and then grade 3 or 4 split out between most common and then those of particular interest. So the most common side effects were diarrhea, nausea, neutropenia, arthralgias, and hypertension, none of which are particularly surprising. So this is in line with what we would expect. The rates of neutropenia were a little bit higher for sure, with 30 to 40%, especially 30% grade 3 to 4, but only one patient in this trial experienced febrile neutropenia, and AFib and bleeding was still quite low. There were no differences in bleeding for those on antiplatelet or anticoagulation, and they actually did not see any lab or clinical tumor lysis in this trial, which is particularly notable. So what that means is the 3-cycle lead-in for ibrutinib was effective in debulking patients' disease, as well as significantly lowering their tumor lysis risk before the addition of venetoclax. And then overall, there were no new safety signals with this. So the takeaways for CAPTIVATE, this was an all-oral, once-daily, chemotherapy-free, fixed-duration regimen that clearly led to deep, durable responses and a very promising progression-free survival. Of course, this is phase 2 data, including in patients with high-risk features. This was a relatively younger and more fit population. There was a really high treatment completion rate for patients receiving ibrutinib and venetoclax, and only 10% of patients even required any dose adjustments of the 2 drugs. And as we discussed, no new It's our younger, relatively more fit patients. One notable thing for the ibrutinib venetoclax arm, those that did have MRD, they actually maxed out the duration of the venetoclax to 2 years. And the primary endpoint for this trial, which is notable, was 1-year disease-free survival in the confirmed undetectable MRD population. So that is what this trial was really designed to look at. So you can see the results in the boxes below here for each arm. So in our patients that did have MRD, they got either ibrutinib or ibrutinib and venetoclax. 30-month progression-free survival was really the same, 95% versus 97%. One notable thing, which we have to remember that this study was not actually designed to look at, is that there was more MRD conversion in the ibrutinib venetoclax arm. So those that continued ibrutinib, the peripheral blood MRD did not really change. However, for those that received venetoclax, they did see improvements in their MRD status. And then for what we're focused on for the purposes of this trial, they looked at 1-year disease-free survival for patients that had undetectable MRD and they got placebo or ibrutinib. And disease-free survival in this trial, they included MRD relapse. So they were strict and they're looking specifically to make sure there's no MRD relapse either. And so the patients that got placebo had 1-year disease-free survival, 95%, and it was 100% for ibrutinib, 30-month progression-free survival, also 95% and 100%. So we can draw the conclusion here that it did not seem to matter if patients got placebo or ibrutinib, which is pretty remarkable, because what that means is if patients have undetectable MRD after this fixed duration regimen, this is basically saying that they may not require any further treatment. Of course, Captivate had a small number of patients. This study in particular was designed with that primary endpoint of 1-year disease-free survival in the confirmed MRD population. So that's the biggest takeaway for us. They did have a very strict MRD definition. So these patients were required to have 2 MRD assessments at 3 months apart, and they had to be negative, and they had to correlate between blood and bone marrow. And then, like we discussed, patients who achieve MRD, it appears they may not require further treatment. Of course, we would need to confirm this in other trials, but I think that's the biggest takeaway, and it's exciting to have the potential to be able to stop a BTK inhibitor. And one limitation of this trial, we weren't really able to evaluate an MRD-guided duration of therapy. And of course, this was a relatively young and fit population. However, we do have a complementary trial, the phase 3 GLOW trial, that was actually done in our older patients. So we have this trial for our other patient population. GLOW was a phase 3 trial, actually, so randomized open-label international multi-center trial. These are patients 65 or older, or those aged 18 to 64 with a cumulative illness rating score of greater than 6 or creatinine clearance less than 70. This was new diagnosis CLL, so similar, and then they did exclude any deletion 17p or TP53. You will see that any trials now that are randomizing to chemoimmunotherapy are excluding deletion 17p or TP53, since it's no longer appropriate to give them chemoimmunotherapy. So the intervention here is ibrutinib and venetoclax with the same regimen. So 3-cycle lead-in of ibrutinib followed by 12 cycles of ibrutinib and venetoclax compared to chemoimmunotherapy, so chlorambucil for 6 cycles. For the results, you can see ibrutinib, venetoclax, and chlorambucil had very similar overall response rates, 87% versus 85%. Progression-free survival, however, was significantly different, 66% versus 19.1% with chemoimmunotherapy, and overall survival was improved as well, 85% versus 63%. They looked at undetectable MRD in the blood and bone marrow, looking at 3 years post-end of treatment, and ibrutinib venetoclax was 55% and 52% compared to 39 and 17 for chemoimmunotherapy. So the takeaway from the GLOW trial is the same regimen, ibrutinib venetoclax, has now been studied on a phase 3 trial and also demonstrated efficacy even in comparison to chemoimmunotherapy. So this means that this is a very appropriate frontline regimen, even for our younger fit patients as well as now our older patients. These trials, of course, answered some questions. However, we probably have more questions too as we go through some of this data. So you may be wondering, well, does this mean BTK inhibitor therapy can be time limited? What would actually be the benefit and the role of an MRD-guided duration of therapy? You may be wondering, okay, well, if we can combine BCL2 inhibitor and BTK inhibitors, can we also add an anti-CD20 monoclonal antibody? And then if we can combine ibrutinib with venetoclax, can we also use acalabrutinib and zanubrutinib, our second-generation BTK inhibitors that we know have a little bit less toxicity? And so I'll go through several trials with the idea of maybe exploring answers to some of these questions. So I'll start with the FLAIR trial. This trial was a phase 3 multi-center randomized controlled open label trial that evaluated an MRD-guided duration of therapy. These were fit patients with untreated CLL. They excluded deletion 17p or TP53. They received ibrutinib and venetoclax, but this was an MRD-guided duration, and they compared it to chemoimmunotherapy FCR for 6 cycles. They started ibrutinib with a 2-cycle lead-in this time, and then they added venetoclax, and then patients underwent serial periodic MRD testing with an MRD-guided duration that went all the way up to 6 years. You can see here, and the blue arrow is the time in months from the treatment start of the combination of ibrutinib and venetoclax, and in the green boxes is the percent of patients that were able to stop treatment. How patients were able to stop treatment is that they had to double the time from the first undetectable MRD in peripheral blood. So for example, if their patient had their very first undetectable MRD in peripheral blood at 12 months, that means they continued treatment until 24 months, so just double the time frame. And then treatment was restarted if MRD was detectable at any point prior to the 6-year mark. So you can see starting at 24 months, about 30% of patients were able to stop treatment, and then it steadily increases up to 50, 60, and up to 70. So at 48 months, I think it clearly kind of steadily increases, but then you can see at the 48-month mark, it kind of plateaus. So it's 70 up to 72, 78, 78. So the results for the overall response rates at 9 months were 76% for FCR, 86% for ibrutinib venetoclax, and estimated 3-year progression-free survival was 76% with FCR and 97.2% with ibrutinib venetoclax. So these are really good results. The overall survival was similar, and the 5-year undetectable MRD was 67% with FCR and 92% with ibrutinib venetoclax. One important thing to note from the subgroup analysis, it did appear that mutated IGHV patients do benefit from FCR. So the FLAIR trial does actually give us a chance to evaluate MRD-guided duration of therapy, and it shows us that these patients actually do have really good outcomes if we can personalize treatment and give them kind of exactly what they need. However, it's difficult to apply the MRD-guided duration of therapy when we also have large-scale trials demonstrating really good results with fixed duration regimens and no kind of real way to directly compare the two. The other thing is that there are challenges with MRD testing and doing it the way that they did in the FLAIR trial. So putting the MRD testing in practice is challenging due to the consistency of MRD testing, the methodologies, the sensitivities. We don't know a lot about the correlation of blood and bone marrow and how much it matters, or how often to measure. Also, when to restart therapy. So for example, in the FLAIR trial, they restarted patients on therapy if they had detectable MRD, but on the flip side, if you offered your patient fixed duration treatment, you wouldn't be checking the MRD and they would have a completely treatment-free interval. And so we just don't have enough information to really recommend MRD-guided duration of therapy, but I think it is definitely something we can consider and hopefully future trials will elucidate for us. The other question is really the correlation of MRD with progression-free survival and overall survival. Like I said, it is pretty clear with our venetoclax-based regimens with anti-CD20, with ven-OB, with ven-Rtux, and even with chemoimmunotherapy. But we will see that there is maybe not as much of a clear correlation, or maybe we just don't know yet what the correlation is with specifically combining venetoclax with a BTK inhibitor. So the next trial we'll talk about is the phase 3 Gaia trial. This trial was a phase 3 open-label randomized trial looking at venetoclax combinations compared to chemoimmunotherapy. This was in fit patients with untreated CLL, no deletion 17p or TP53. So 926 patients were randomized either to chemoimmunotherapy for 6 cycles, venetoclax and rituximab for 12 cycles, venetoclax and obinutuzumab for 12 cycles, and then ven-OB ibrutinib for 12 cycles. So these are all fixed duration regimens. The ven-OB ibrutinib arm, actually, they stopped ibrutinib if patients had 2 consecutive undetectable MRD assessments, so they didn't continue the ibrutinib long term. And so this trial really was designed to evaluate chemoimmunotherapy versus the venetoclax-based regimens. And so for overall response rates, you can see they're clearly improved with the venetoclax-based regimens. The progression-free survival is it's lower in our FCR and BR arm, 80% with ven-Rtux, and then 87 and 90% with ven-OB and ven-OB ibrutinib. So clearly those have a improvement in progression-free survival. And then overall survival too is different there. And then undetectable MRD is improved in the ven-OB arms as well as ven-OB ibrutinib. However, one of the questions that we hoped maybe this trial could answer was the utility of the triplet therapy. And so what we found in this trial, you can see the progression-free survival is really not different between those two, the doublet and the triplet therapy. And we did see more grade 3 to 4 infections with triplet therapy. And unfortunately, this trial wasn't necessarily designed specifically to evaluate that either. So we can't draw any concrete conclusions, but I do think this, based on this trial, there is still questionable utility of triplet therapy. And then this brings me to probably the most exciting and big update we have in frontline treatment of CLL. This is the phase 3 Amplify trial that was just presented or published just very recently. Amplify is a phase 3 multi-center international randomized trial in patients aged 18 and older with previously untreated CLL. They also excluded deletion 17p and TP53, and they included patients with ECOG 0 to 2. They did exclude patients older than 65 with a cumulative illness rating score of greater than 6. These patients received fixed duration acalabrutinib with venetoclax with or without OB compared to chemoimmunotherapy. So they received acalabrutinib for starting with cycle 1 through 14. So they started with acalabrutinib and then they added the venetoclax in starting with cycle 3 and continued it for 14 cycles, and then with or without OB, but the OB was started cycle 2 for 6 cycles. The primary endpoint of this trial was progression-free survival of the acalabrutinib venetoclax or AV arm compared to chemoimmunotherapy, and the median follow-up was 40 months. So on the right, you can see the results for the AV arm, the AVO arm, and then FCR or BR. Overall response rates were higher with our acalabrutinib venetoclax arms, and 92% versus 75%, and 36-month progression-free survival was 76.5%, 83%, and then 66%. Our overall survival was actually 94% in the AV arm, and then 87% in the AVO arm. So there are some interesting things to note here. Our progression-free survival was the best in the AVO arm, so the triplet therapy did result in the best progression-free survival. However, you see that the overall survival is actually higher in the AV arm. These are preliminary results for Amplify, so I think we'll wait for a little bit more clarity on this. But what happened was Amplify did have to deal with a lot of COVID-related issues, so there were overall a lot of COVID-related deaths in this trial, and we'll talk about the deaths overall, but the AVO arm had the most infection-related deaths. So I think that is what impacted their overall survival. And then what you can see for MRD here is the 45% for AV and then 95% for AVO. That too is a little bit, it's lower than what you would expect based off of everything that we've been seeing. So that too is something that I hope we have a little bit more information on at some point. However, again, I think patients weren't able to complete as much MRD testing because of COVID impacting this trial design quite a bit. It also might be related to the timing of MRD testing. So this is MRD just right at the end of treatment, so it's possible that that wasn't exactly the right time point. But you can also see that it doesn't actually impact the progression-free survival that much. It's not a clear difference. So it might also mean that we just don't know how much undetectable MRD matters and correlates with progression-free survival with this particular regimen. However, there was a 90% treatment completion rate for AV, so it was a very high treatment completion rate. And then based off of the subgroup analysis, AVO may be preferred for our IGHV unmutated patients. In terms of the safety data, you can see here split out between acalabrutinib, venetoclax, AVO, and then FCR. And then the first one is AEs leading to treatment discontinuation, which was highest in the triplet therapy, 20%. Death from any cause is kind of what I was referring to as highest in the triplet therapy, presumably due to infection and COVID-related deaths. And then adverse events of particular interest. So we have AFib, hypertension, bleeding, neutropenia, infection, and tumor lysis. So you can see AFib overall was rare and as expected with acalabrutinib, same with hypertension and bleeding. The neutropenia was actually relatively high across all groups, including grade 3 or higher. However, you can see that the grade 3 or higher infections are particularly higher in the AVO arm. And then there was a very low risk of TLS overall. So before I jump into conclusions from this, also want to mention, since we talked about the updates for acalabrutinib, zanubrutinib also has some really exciting stuff coming out. So zanubrutinib is being combined with venetoclax in Arm D of the phase 3 Sequoia trial in previously untreated CLL. And then zanubrutinib is also being combined with sonrotoclax, which is a novel, new, selective, potent BCL2 inhibitor that actually has efficacy potentially against venetoclax-resistant patients. And so both of these have really promising preliminary results. So it'll be exciting to see how this shakes out. But in summary, additional studies will further elucidate the role of an MRD-guided duration of therapy. I think we definitely need more data, again, to fully understand the utility of a triplet regimen compared to a doublet regimen. We saw both, even in the Amplify trial, that triplet therapy does clearly result in an increased risk of infections and toxicity. And despite the limitations of Amplify, I think that has been demonstrated elsewhere as well, without a clear progression-free survival benefit. So I think for now, most would tend to stick to a doublet therapy until we have data otherwise. And an all-oral BCL2 inhibitor and BTK inhibitor fixed duration combination, even utilizing not just ibrutinib, but a second-generation BTK inhibitor, may be used in the frontline setting. And this is a really exciting update. I started this section by saying, what we are still looking for is an all-oral, convenient, fixed duration, fully outpatient regimen. And we now have that, and we can offer our patients that in the frontline setting, which is pretty exciting. All right, so this brings me to my next audience response question. So which of the following is true based on the phase 2 Captivate trial evaluating ibrutinib venetoclax for previously untreated CLL? Is it A, the study excluded patients aged 70 and older? Is it B, the study excluded patients with TP53 or deletion 17p? C, ibrutinib and venetoclax resulted in high rates of undetectable MRD, and D, TLS was common in patients receiving ibrutinib venetoclax. All right, and we actually have two right answers, which are both correct. So high rates of undetectable MRD, as well as the Captivate was our younger and fit population, whereas GLOW was the complementary older population. And this was phase 2 trial, so they did include TP53 and deletion 17p. All right, so to summarize our frontline updates, we're questioning whether BTK inhibitors need to be indefinite therapy, and we have the addition of venetoclax, acalabrutinib with or without OB, as well as ibrutinib venetoclax in our frontline treatment. Okay, so now we can move on to our relapsed and refractory regimens. And we'll be focused on our updates here. So as I was discussing, when we start with a venetoclax-based regimen, we'll often move to BTK inhibitors and then vice versa. But some key updates that I wanted to discuss today are the addition of obinutuzumab in the relapse setting. Historically, we have used venetoclax rituximab in the relapse setting based off of the Murano trial. However, there is some data now to use OB in the relapse setting, which I'll discuss. And then also ven-OB can also now be used in relapse after it's been used in the frontline setting after a period of remission. So I'll discuss the venetoclax retreatment data as well. And then after that, we'll get into patients that have progressed on both covalent BTK inhibitors and BCL2 inhibitors. All right, so first I'll start with the venetoclax retreatment. So this was evaluated in a multi-center international retrospective trial. This was a study done in previously treated patients with CLL that had received some type of venetoclax-based regimen. We'll call that VEN1 in any line of therapy, and then retreated with a second venetoclax-based regimen. We'll call that VEN2 in a later line of therapy. You can see the treatment characteristics here. Patients had a median of 16 months between VEN1 completion and then start of VEN2. 85% of patients had at least a 6-month interval, and then 60% of patients had at least a 12-month interval. The median time on VEN2 was 10 months. On the baseline demographics on the right, you can see that these patients had a median of 2 prior lines of therapy. 90% of patients received VEN1 in the relapse setting. So they're using it in the relapse setting and then still giving it again. These patients presumably received chemoimmunotherapy, but 40% of them had also received prior BTK inhibitors. And the most common VEN1 regimen was venetoclax with rituximab, which makes sense since this is the relapse setting. And then for VEN2, they received monotherapy as well as ven-ritux and ven-OB combinations. We can see the results of the venetoclax retreatment here on the right. So an overall response rate of 80%, and then median progression-free survival was 25 months, and then undetectable MRD in the blood in 41.7% of patients. Now, this was a really small trial and retrospective in nature, and there were only 12 evaluable MRD patients. So it's not strong data, but ultimately it does demonstrate retreatment with a venetoclax-based regimen is feasible, and it appears to be effective for patients with CLL that have been previously treated with a venetoclax-based regimen. You're probably wondering, well, then what is the ideal time frame with which we should be able to offer patients a venetoclax retreatment? And the median time frame was 16 months. The majority of patients had at least 6 months, so I would consider that an absolute minimum. However, given the median was 16 months and then 60% still had at least 12 months, I think we can translate that to at least 1 to 2 years of a remission if we're retreating. However, I wouldn't necessarily offer this to everyone. We do obviously have other options available, so I think that retreatment could actually be a really good option for patients that are not BTK inhibitor candidates for some reason, or if you have a patient that is just really wanting a fixed duration regimen. We have patient discussions, and often when you offer a fixed duration regimen, they will choose that over any kind of indefinite therapy, so I think there is still a role for this. And we'll be awaiting larger scale, not retrospective data to confirm this, as well as with using venetoclax in the frontline setting and then retreating. And then the other big update we had was using OB in the relapse setting, whereas historically we've used rituximab. And there's a lot of interest in this because frontline data has demonstrated that OB is better in the frontline setting. And so extrapolating that, it makes us wonder, well, shouldn't we be using OB in the relapse setting as well? So this was a retrospective real-world data evaluating OB-ven in the relapse setting, and they continued venetoclax for up to 24 cycles, which the frontline OB-ven regimen is 1 year and the relapse setting is 2 years, so it makes sense for relapse that they used up to 2 years of therapy. These patients had a median age of 72, 28% had TP53 or deletion 17p, and many had received chemoimmunotherapy, CD20 monoclonal antibodies, and covalent BTK inhibitors. The overall response rate here was 90%. 2-year progression-free survival was 81.2%, and undetectable MRD in 56% of patients. So again, this is really promising data, and I think it at least demonstrates that there is some data to use OB in the relapse setting, and we will again have to await larger scale trials to actually confirm this. However, it is now incorporated into treatment recommendations to use OB in the relapse setting. Okay, and now we'll jump into our last section here, really talking about our patients that have had disease progression on both covalent BTK inhibitors as well as BCL2 inhibitors. Prior to the advent of these newer therapies, such as pirtobrutinib and CAR T-cell therapy, we were unfortunately having to reach for things like small molecule inhibitors, PI3 kinase inhibitors, which are very toxic, and so it's exciting to have some other options. So what is pirtobrutinib? Pirtobrutinib is a non-covalent BTK inhibitor, which means it has reversible binding. What that means is that it can bind to mutated BTK. It's highly potent and selective. It has a half-life of 19 hours and sustained BTK inhibition during that dosing interval. And it can work, again, regardless of common resistance mutations such as C481S and then even potential PLCG2. Pirtobrutinib was evaluated in a phase 1/2 trial, multi-center trial called Bruton in patients with relapsed refractory CLL with failure of at least one prior BTK inhibitor. It was given at a dose of 200 milligrams daily. Patients could have failed the BTK inhibitor either due to progression or intolerance. The median age of this trial was 69, but you can see that they included patients all the way up to 88 in the actual trial, and ECOG 0, 1, and 2, so this is an older and potentially more frail population than what we've been seeing, and deletion 17p or TP53 in 36% of patients. They had a median of 3 prior lines of therapy, and this was a pretty heavily pretreated population. You can see their previous therapies here. Everyone received BTK inhibitor, but the majority had also received chemoimmunotherapy, anti-CD20, and 40% of BCL2 inhibitor. They had also received CAR T-cell therapy, which is notable since we'll be talking about that too. And then most patients had, of course, had disease progression, and 34% of patients had the C481S mutation. The results here are split out between all patients and then prior BTK inhibitor and BCL2 inhibitor. And our overall response rates are similar, 80%. Median progression-free survival was 19.6% in all patients and 16.8% in prior BTK and BCL2 inhibitors. The subgroup analysis did note that the PLCG2 mutated population didn't seem to have a clear benefit. Those are really small numbers because it's rare, so it's unclear if it really means anything clinically significant. However, I think further studies will need to confirm the efficacy of pirtobrutinib in that population. For the safety of pirtobrutinib, actually, it was a very well-tolerated therapy. So the most common side effects are exactly what you would expect with a BTK inhibitor: bleeding, bruising, neutropenia, and then hypertension, AFib. The neutropenia was a little bit higher, but this did not result in a significant risk of infections. The grade 3 and 4 infections are still 3.8%. And AFib and major bleeding were still quite rare. Even slightly, the numbers are slightly lower even than our second generation BTK inhibitors, such as acalabrutinib and zanubrutinib. So the takeaways from the Bruton trial, this was, of course, a heavily pretreated and high-risk patient population. Pirtobrutinib demonstrated efficacy in patients that had received a prior BTK inhibitor and BCL2 inhibitor. Treatment sequencing remains a question and is something we'll touch on later. We don't know much about resistance to pirtobrutinib. We will find that out as we use it a little bit more. But the safety profile of pirtobrutinib was extremely favorable, a very well-tolerated treatment. And then ongoing trials are evaluating pirtobrutinib in the phase 3 setting. All right, so this brings me to my third audience response question. PG is a 70-year-old male who was initially diagnosed with CLL in 2015. He received therapy with zanubrutinib and now has progressive disease. He presents today and has questions about pirtobrutinib. Which of the following is true regarding pirtobrutinib? Pirtobrutinib is not an option for PG, given he has only tried one prior BTK inhibitor. Pirtobrutinib demonstrated superior outcomes for relapsed and refractory CLL in a phase 3 control trial. Pirtobrutinib is a non-covalent BTK inhibitor. And D, pirtobrutinib has a higher risk of AFib compared to other BTK inhibitors. Okay, perfect. So yes, pirtobrutinib is a non-covalent BTK inhibitor. It's not yet been studied in phase 3 setting. It is certainly appropriate for someone who has failed any prior covalent BTK inhibitor and has a potentially lower risk of AFib. Okay, and then we'll move on to our last big update in the relapse setting, which is CAR T-cell therapy. CAR T-cell therapy for CLL was evaluated in the phase 1 and phase 2 Transcend trial in relapsed and refractory CLL with at least 2 prior therapies, including BTK inhibitors. These patients underwent lymphodepletion with fludarabine and cyclophosphamide. This was a dose expansion study, so they chose to expand dose level 2 in phase 2 setting. The primary endpoint was CR in a pre-specified subset of efficacy evaluable patients with previous BTK inhibitor progression and venetoclax failure, but the venetoclax failure could include both progression or intolerance. The baseline demographics for Transcend, the median age was 65. These patients were younger. Obviously, the oldest patient they had in this trial was 70, ECOG 0 to 1, and they had a very high-risk patient population. There were 46% of patients with TP53 mutations. This, too, was a heavily pretreated patient population, so they had 5 median prior lines of therapy. Most had received BTK inhibitors, BCL2 inhibitors, and most had obviously progressed on those therapies. The results here are split out between full population and then prior BTK inhibitors and BCL2 inhibitors, and overall response rates are similar, 48% versus 43%. Undetectable MRD in 65% and 62%. Time to first response was different, 2 months in the full population and then 1.1 month in the patients that had received both BTK and BCL2. The duration of response was 35 months, which is pretty good. And then progression-free survival was 18 months in the full population and 12 months in our patients that had received prior BTK inhibitor and BCL2 inhibitor. For safety, the CAR T-cell therapy, lisocabtagene, actually resulted in very classic side effects, so what you would expect with any CAR T-cell therapy. So 85% of patients had CRS, 9% was grade 3 to 4, 35% of patients required tocilizumab, and we also saw other adverse events that we would expect to see with CAR T-cell therapy, such as prolonged cytopenias and infections. So Transcend definitely represented a heavily pretreated high-risk population. They did include younger and more fit patients overall. We saw durable responses despite, and we saw MRD responses despite standard response criteria. So the overall responses were lower with CAR T-cell therapy, but that didn't translate to the actual other clinical outcomes. Of course, CAR T-cell therapy has some more safety concerns. There were classic CAR T-related side effects, but compared to something like pirtobrutinib, definitely more notable. And pirtobrutinib was not available during the time of this study, so it doesn't allow us to comment on sequencing. We also have epcoritamab, which I just want to briefly mention is approved for lymphoma and probably something that we'll see in the CLL space as well. It's a bispecific, and it's targeted to CD20, and they're evaluating in early stages a phase 1b and 2 trial where they saw a pretty high incidence of CRS, so they're adjusting the dosing to minimize CRS. But we'll probably be able to hopefully have this as an option as well in the future. So how do we actually select therapy in the relapse setting? So we have our two main updates that we talked about, non-covalent BTK inhibitor pirtobrutinib, and then lisocabtagene, our CAR T-cell therapy. So pirtobrutinib did include patients that were post-CAR T. Pirtobrutinib, like we discussed, had a very favorable safety profile. It is oral, and the study included patients of all ages and performance statuses. The CAR T-cell therapy, no patients received pirtobrutinib. These were younger and more fit patients, and it had a more significant toxicity profile, at least when you compare it directly to something like pirtobrutinib. So how do we decide what to use? A lot of that is patient considerations, patient's age and performance status, their comorbidities, their quality of life, their preference maybe for oral versus IV treatment, their preference for time-limited versus continuous treatment. They also, at this stage, will probably have a strong preference in time in and out of the hospital, and that is something I think we can focus on when we're selecting between pirtobrutinib and CAR T-cell therapy, as well as social factors and tolerability. Tolerability, I think, is the other big thing we can focus on when we're choosing between these two. I think that the average CLL patient who is a little bit older and more frail and may not necessarily want something as intense as CAR T-cell therapy, pirtobrutinib is a great option for those patients. Unfortunately, we're not going to have data for patients that have received pirtobrutinib and then gone on to CAR T-cell therapy, but I think just given the safety of pirtobrutinib, I would recommend that first, and then if a patient still needs therapy, they may be able to get CAR T-cell therapy if they are fit enough. Okay, so this summarizes our updates in the relapse refractory setting of using OB-ven, as well as using OB specifically in the relapse setting, and then OB-ven retreatment. Also, for patients that have progressed on covalent BTK inhibitors and BCL2 inhibitors, pirtobrutinib, and CAR T-cell therapy. Okay. Sorry, I'm gonna just... So to tie it all together, how do we actually design a treatment algorithm and sequence our treatment? So this is a brief algorithm starting at the top with patients that have received a prior covalent BTK inhibitor or BCL2 inhibitor. On the left, you can see for a patient that has received a covalent BTK inhibitor, the next step after that would likely be venetoclax with obinutuzumab. After that, if a patient has relapsed again, they may qualify for ven-OB retreatment with the same caveat that I think this is most reasonable for options that for patients that have had at least 1 to 2 years of prior response to their treatment, and also for those patients that are really wanting a fixed duration therapy. You can also move along and not do ven-OB retreatment for the patient that maybe that's not a good option for, and move on to pirtobrutinib, but regardless, I think pirtobrutinib is the next step after that. On the right, you see for patients that have received a prior BCL2 inhibitor, those patients still can get ven-OB retreatment with all of the same caveats. And then after that, those patients should get a covalent BTK inhibitor. After progression on the covalent BTK inhibitor, they should still get pirtobrutinib likely, and then I-reserve CAR T-cell therapy is the last line therapy simply for safety reasons. However, we want to make sure that our patient is fit enough for CAR T at that point. All right, and this brings us to our final audience response question. RT is a 74-year-old male with relapsed and refractory CLL who received acalabrutinib at diagnosis several years ago, and then most recently venetoclax with an anti-CD20 monoclonal antibody upon disease progression. He has now progressed again within 5 months. He wishes to preserve his quality of life and prefers to be treated with less intensive therapy at this time. Which of the following is true regarding his treatment options? Is it A, RT should be retreated with venetoclax and an anti-CD20 monoclonal antibody? B, RT is not a candidate for pirtobrutinib because he had progression on acalabrutinib. C, CRS was rare in patients receiving lisocabtagene. And then D, RT is older than the patient population included in the TRANSCEND trial evaluating lisocabtagene. Yes, that's exactly right. So RT is older than the typical patient population that was included in the CAR T cell therapy. All right, and I'll just end with a mention for BTK degraders, which is a new drug class that's in the pipeline. Very exciting because it's a new mechanism. BTK degraders would result in proteasomal degradation of BTK, and they have the potential to overcome limitations of BTK inhibitors, including BTK resistance. There's 2, NX-5948 and BGB, that are currently being evaluated in very early stage trials. However, we have seen responses in prior BTK inhibitors, prior BCL2 inhibitors, and even prior pirtobrutinib. So this is something that will be really exciting for us to see the final results of. So in summary, we have some novel combinations for the treatment of CLL, an all-oral combination of BTK inhibitors and venetoclax, and I think that is the future of CLL therapy, is an all-oral fixed-duration regimen. CLL therapy may also shift toward MRD-guided durations or just fixed-duration regimens entirely. For patients with prior covalent BTK inhibitors and venetoclax, our options include CAR T-cell therapy and non-covalent BTK inhibitor pirtobrutinib. And of course, treatment sequencing can certainly be difficult with evolving therapy. For example, we just had the acalabrutinib venetoclax update. So of course, that changes things when we're using both drug classes in the frontline setting. So treatment sequencing will always be a challenge, but it's a good problem to have when we have new drugs we can use. And with that, I'll take any questions.
We're at time, excuse me, we're at time, but we will, for those who want to stick around, we'll answer at least a couple questions. Great job, audience, for upvoting the questions. I was happy to see that like 40 people want this first question answered. So the first question here is, what are your thoughts on several trials, GLOW, Amplify, et cetera, using substandard comparators, and how can we draw conclusions when it's not compared to standard of care that we would do now?
Yeah, that's a really good question. So the question is, how can we draw conclusions from many of these trials using substandard comparators? That is obviously difficult, and ideally we would have perfect trial design that can give us like very current standard of care therapy. Unfortunately, there is no perfect way to draw conclusions outside of just evaluating the trials that we do have. I still think that obviously, just given what we have, those trials still demonstrate efficacy for our novel combinations, and we just have to keep in mind that we don't have the perfect trial design yet for these regimens.
Great. That's all we have time for. Thank you.